Welcome to Adapting Class. Thank you for joining us today. So, we'll be talking about some endocrine concept. This is diabetes insipidus. I know you know about it, but there's some concepts you need to know about it. There's a way they can ask you questions that can be confusing. I'll just give you a brief note that you can use to answer questions. Then we do a case study and you can see how we apply. So, diabetes insipidus is actually not one thing. There's three things that happen, right? It's due to water balance. So there's a water balance issue. Why do we have water balance issue? It's because of either there's no or ineffective ADH, right? Anti-diuretic hormone. So, or it can be resistant. So either ineffective, no, or resistant ADH. Basically, you're not responding to it. Remember, ADH, which is anti-diuretic hormone, is anti-diuretic. So against diuresis, right? It does not want you to really um, have a urine output, like urinate. So it's against diuresis. So if you don't have it, you're going to have a lot of diuresis. That's the way you can think about it. So you have excess um, loss of water. But this is coming from your brain. Most of the time from the brain, from the pituitary, right? It's from the pituitary gland. That is where it's secreted. And we secrete it based on our water balance. So if your blood concentration is too high or low, your body will try to secrete these hormones. Do the same thing, either whichever the situation is. So this is the way you can think about it. Water balance issue, whether it's effective or ineffective, or your body is not responding to it. That is the idea. So when your concentration of your blood is high, your body releases a lot of ADH so that you can absorb water to decrease it. If the concentration is too low, we don't absorb any water and get rid of the water and bring it normal. Okay. The problem is there's three types. Like I said, there's three types of ADH. It can be central. So if you see a question, don't worry about it. Just based on the first thing they put in central, which is this is neurogenic. Okay, neurogenic cause of diabetes insipidus or nephrogenic. That means it's from your kidney, right? Or is you. We call it dysprogenic, and I will explain it to you, you later on. So dysprogenic. What does that mean to have a neurogenic cause? Neurogenic cause means your brain damage. So neurogenic. It's the brain that is the problem. Neurogenic. That means brain trauma or you have surgery. Sometimes it may be because you have a tumor, or sometimes we don't know, idiopathic, right? And so when the brain gets damaged, usually the pituitary ADH is not secreted from the pituitary gland. So this is the problem is you don't have ADH because so lack of secretion, lack of it because your brain cannot secrete it. And this is the key thing about neurogenic. If it's nephrogenic, so this is the how you can master them, right? Nephrogenic. When you see the question is nephrogenic, it means your kidney um, does not recognize ADH. That means you have it, but your kidney cannot see it. Most of the time, it's medication. Number one medication that causes this is lithium. Lithium is very smart. That's why it causes dehydration. It's because it makes you not see ADH. So lithium is number one cause of nephrogenic diabetes insipidus. Patient who is on lithium would develop DI because not because they don't have ADH, but they have it, but they cannot recognize it. So the ADH doesn't do anything. Or if I give you this medication, democlocycline, this is why we use it. It's antibiotic. We use it to treat patients who have SIDH, right? They have SIDH, they have too much ADH. If I give you democlocycline, it will destroy, basically, it will prevent the SIDH from manifesting itself. So we block ADH. That's the problem. As democlocycline block ADH. If you have lithium, it's going to stop ADH from working. Your kidney cannot see it, and you develop nephrogenic diabetes insipidus. The third one, you may have heard about it, but this is usually common in patients who have psychotic problem. This is classic. People who have psychotic problem, we call it dysprogenic. And there's a damage, right? There's a damage to their test center in your brain. There's a reason why these people drink a lot of water, right? The third center in their brain is damaged, usually psych illness, and therefore they drink too much. And when you drink too much, a big excess fluid intake, it suppresses ADH. So this is what happened to them. So you have to know the difference: neurogenic, nephrogenic, and then a dysprogenic. That means your brain is basically test center is being destroyed because you drink too much and you have psychotic problem. Second, you have to know how to treat these patients, but you have to also have to know what kind of features you're going to see. So what do you see when a patient has basically DI? In all of them, the signs and symptoms is what your board like, signs and symptoms, right? They're going to be testy because they've been drinking a lot of water and then they lose all the fluid. So first one is polyuria, right? They're going to pee a lot and then they will be testy, right? Polydipsia. So it look like somebody who have diabetes, but it's DI or something like that, but it's not. This is due to the brain injury. And then they will have dehydration. If you pee too much, you develop dehydration, right? If you have dehydration, what? Hypotension. That's what happened. If you're hypotensive, what happened? Tachycardia. You see what I'm doing? I'm trying to deduce information from the content. So you should do that when you're taking, when you're studying. You don't memorize signs and symptoms, but you can make it up. If you have polyuria, you pee too much, you get testy, polydipsia. If you get testy and you try to drink and pee, you get dehydrated. Dehydration, you become hypotensive. Hypotensive, you develop tachycardia. What happened? You have dry mucous memory, right? And then you get fatigue. Do you have to memorize these signs and symptoms? No, this is what you expect. And if you get fatigue, you get dehydrated, you get confusion due to what happened to all the signs and symptoms associated, all come together and it develop that. What your body will ask you is this. Also, don't forget this lab work. What should you expect? Don't memorize it. This is a select or apply, so don't memorize it. Like I told you, we have a certain concentration in our blood. We have a certain concentration in our urine. But when you have DI, it changes. Remember, diabetes insipidus, you're losing water. So if you lose too much water, what happened to your blood concentration? What do you think? If you lose too much water, your blood will become concentrated. So we call it blood. Blood is the osmolarity. So blood osmolarity is going to be high. So you get elevated. Whenever blood osmolarity is high, sodium go the same direction. So you don't have to memorize. So your sodium, so blood sodium, serum osmolarity, serum sodium also goes high. It follow the same direction. So this become high. If the blood is concentrated and you pee a lot, your urine become what? Dilute. So your urine osmolarity, which is the same as specific gravity, is going to go what? Down, low. And your urine sodium okay, also go low. Your urine become what? Dark, it become pungent, any smell. This is a select and apply. You should not mix. It's a free answer choice. You should never forget it. If they give you no mix, it's easy. Your urine specific gravity, this is the normal, 1.003, and flip the zero back, 1.030. So if your urine specific gravity is low, it should be less than 1.003. If it's high, it should be greater than 1.030. That's all. That's the key aspect you have to know. These are the way they will confuse you. Now, treatment. How do you treat it? Think about what I said. In treatment, so let me put it here. The treatment, number one, is nephrogenic. Let's start with neurogenic. Neurogenic, that is what they will use the word central. Central is central DI. That's what everybody know. Everybody know about central. Central means your body, your brain is not making ADH. Therefore, if he's not making it, the treatment is to give the individual ADH. That's number one. Okay. Number one is give them the ADH. We don't have any ADH, so we give you desmopressin or vasopressin. And since you very dehydrated and your urine sodium, your blood is very concentrated, we give you hypotonic solution. That's all, right? And you let them drink. So hypotonic solution, let them drink. But this is the key treatment you have to know. And desmopressin, give them IV fluid and monitor their virus. If it's nephrogenic, is the kidney, right? Nephrogenic is because you're taking certain medication like lithium or you're taking desmoclocycline. Stop the desmoclocycline. That's all. Or if it's lithium, stop the lithium. But if you cannot stop the lithium, there's a medication you can give. This is thiazide. Don't forget, thiazide is the number one medication for the treatment of nephrogenic diabetes. It prevents loss of fluid, even though it's a diuretic, it's a different way. It acts a certain way when you have nephrogenic diabetes insipidus, and that helps with the situation. If it's dysprogenic, that means psychotic problem, then all you need to do is to prevent them fluid restriction. That's all. If they drink too much, don't drink too much. And this is the key how to know the difference between all of them. Don't forget, this is a brief information, but this is all you need. You don't need anything to understand the difference between each level of diabetes insipidus, and then how to recognize which one is nephrogenic, which one is central, and which one is dysprogenic. There's something you have to know, right? If it's central, okay, and I deprive you from drinking anything, it's still not going to solve the thing because you don't have ADH. That's the thing. Remember, if it's nephrogenic, if I give you desmopressin, it's not going to work. Those two things, don't forget. Fluid restriction does not solve central. That means your brain cannot make ADH. So it's only for dysprogenic, right? And then desmopressin does not solve nephrogenic kidney problem. Therefore, because the kidney does not recognize it, so if you give them ADH, they're still not going to work. It works for central. In all, nursing care is the same, right? Nursing care is the same. You have to do certain things as a nurse. First, monitor, right? INO. You got to check their vitals, right? Right? Watch for signs of dehydration. right? Replace the electrolytes, and then you have to give them hypotonic fluid to bring their sodium down, right? You got to educate them about medication. These are all nursing care for all of them. It's very, very important. And then you got to monitor their mental status. Why, guys? Why mental status is number one? This is number one when somebody has diabetes insipidus and you're treating them with the desmopressin or you're taking care of them. You have to monitor them after you treating them, you're giving them desmopressin or doing everything. You have to monitor their mental status because now what is going to happen to them? You have to monitor their mental status because they will turn into SIDH. When you're giving them too much and ADH, they will turn into SIDH and their sodium become what? Hypotonic, very low, low sodium, hyponatremia, and then they go into seizures. That's why mental status is very important. You wanted somebody asks what kind of hypotonic solution? Any hypotonic solution. You can give them free water or half normal saline. Don't give them 3%. 3% is used for SIDH. So hypotonic solution is what? Free is for central. For central. These treatment, you can give them D5W water. It's just free water to dilute the sodium that is already high. Remember, their specific gravity is high and their serum sodium is high. So you give them D free water, which is D5W, or you give them half normal, so 0.45% of normal saline. That's what you give them. Don't give them normal saline. If you choose normal saline, is a wrong answer. If you choose 3%, is a wrong answer. That is for SIDH. But this is a brief, very high yield information regarding management of diabetes insipidus. It's not only one. So if you see a question, if you've seen a question before and they said central, they said uh, nephrogenic, they mean something. They're trying to tell you it's not the normal SID, no, a DI, but this is the different, and their management is different. Remember, central, you need desmopressin. That's the priority. If you're nephrogenic, give them thiazide or stop the medication causing that dysprogenic fluid restriction. This is a brief high yield content regarding diabetes insipidus. So this is the question. As you can see, this is the content related. So how do you answer the question? Start from the last portion. Which statement by the client indicates a need for further teaching? That means he or she is not saying something right. And then she's teaching a client with newly diagnosed central diabetes insipidus about desmopressin. So this question is on desmopressin. How do you take it? What do you watch for? What complications should you expect? And what things when the patient says that you have to intervene, right? These are some of the things you have to know. What is the purpose? How do you approach this question? Look at the way I'm going to answer them. Further teaching, that means they're saying something wrong. I put it down. That's my buzzword. Then I said, a nurse is teaching a client, teaching with newly diagnosed what? Diabetes insipidus. There is a central there. That means I know they don't have ADH. So lack of what? ADH. I'm bringing my content about desmopressin. That's why we give them desmopressin. Okay. What is desmopressin going to do? It's going to prevent them from having too much fluid, losing too much fluid. So they're going to retain fluid, right? When they retain fluid, their sodium goes down, right? Their test will go down. Their urine output will go down, but all will normalize, right? So which statement is the patient saying that is need further teaching? The medication help reduce how much I urinate. Oh, yes, it's going to decrease your urine output. Is anti-diuretic. Therefore, it's going to stop you from urinating. I can skip dose when I feel okay. You should not skip a dose. You have to take it continuously. You can do that. When you do that, then you have fluid loss again. So you got to take it as prescribed. Just because you're feeling good, you should not do that, right? I will keep track of my daily weight because you're going to start retaining weight content. This is the how you test taking strategy. The full ADH is going to keep you from losing water. So you're going to retain water. So if you gain weight, let me know. This does not need further teaching. This is the same thing. If we watch our questions are framed, there's always something that sounds the same. C and D are the same. You should not choose D and leave C behind. One said, I will keep track of my daily weight. Therefore, I'm expected to gain weight. And D said, I should report any signs of water retention. What do you think is water retention? Test taking strategy is the same thing. NCLEX do that all the time. When you watch, you take questions on Q banks, it's the same thing. The question answer choice is framed differently. So watch for that so that you don't get trapped. So C and D is saying the same thing, and therefore this is the right answer. You should not skip the medication. Okay. Which medication should the nurse anticipate the provider to prescribe? What is why? Buzzword, anticipate. What are they talking about? A client diagnosed with what? You see the word nephrogenic diabetes insipidus. If you don't know what is nephrogenic diabetes insipidus, trust me, you're going to pick A. But I will show you test taking strategy. Even if you don't know, you can answer this question. I intentionally said this question. If you look at it critically, okay, I have nephrogenic diabetes insipidus. Assuming I don't know what is nephrogenic. I thought it's diabetes insipidus. Okay, fine. That means I know the patient need ADH. Look at it. Desmopressin and vasopressin are the same. Which one are you going to pick? Something should strike you and say, I'm making a mistake. I see desmopressin and vasopressin. If I choose one against the other one, I'm wrong. There's no brainer. These two are the same medication. 3. If you know a little bit of content regarding democycline, you know this is an antagonist. It block ADH, right? It block ADH. Therefore, if I block ADH, it's not going to work. Nephrogenic diabetes insipidus is the same thing as I'm blocking ADH. If I give you democlocycline, you develop nephrogenic diabetes insipidus. If I give you lithium, you develop nephrogenic diabetes insipidus. You see how why content is very important. You don't memorize, you master that. And when you answer the question, don't jump the gun. Look at each question, answer choice, and try to tear them apart. You'll be able to figure out what the answer is. You see, one answer choice is sitting there. It said, pick me. Right. We just talked about it. So I know you picked the right answer. But go through that motion and you see that all the questions are easy. You will be able to get rid of them. Okay. So thiazide. We talk about it. Which finding is most concerning and should be reported immediately? Prioritization 101. Which one is deadly? You have 1 second. What would you do? A nurse is monitoring a client with the suspected diabetes insipidus. You bring your content. The buzzword is diabetes insipidus. Most concerning about diabetes insipidus. I know I'm going to be thirsty. I know I'm going to pee a lot. I know I'm going to get dehydrated. I know I'm going to have dry mucous memory. I give you all the signs and symptoms. But which signs and symptoms tell you I'm dying and I don't have time, right? That's the way you approach prioritization question. Of course, hypotension is bad. Which of the following findings should the nurse expect? That means I should expect, right? This is what I told you in the lecture. select or apply. And nurse is caring for a client with what? Central diabetes insipidus. I'm just putting the content together in the question form so that you can see what I mean instead of just leaving that alone, right? So, central diabetes insipidus is the original one. That means you don't have ADH. You're going to pee a lot. Your serum osmolarity will change. Your serum sodium will change. Your urine specific gravity will change. Your urine sodium will change. Your hemodynamics will change. What do you think? Which of this you should expect? Is a selected apply? You don't need to pick all of them. You pick those you're confident. Once again, you pick those you are very confident about it. Test taking strategy. I told you in DI, central DI, your serum osmolarity goes up. And then sodium follow the same direction. You see? So don't pick D and leave A alone. You see? And then you're losing a lot of water. You're going to get dehydrated. Dehydration shows what? That. Right? That's why your blood pressure is low. You pee a lot, polyuria. If your serum osmolarity is high, your urine osmolarity cannot be high. It should go down. So this is what it is. You don't have to pick all of them. Just pick those you're confident in about. But they are all interconnected. You can break them down. You can figure out what they are, and you can get the answers easily. So if you need more, you should check out Adapting Class. I have videos on it. I will post. Yeah. Okay. Same thing. A client is undergoing a water deprivation test. You may never heard about it before, but think about it. Water deprivation. That means I'm depriving you of water. I'm not letting you drink. Which finding confirms central diabetes insipidus? This is a hard question, but don't worry. If you look at it carefully, you can answer it. It means if I let you stop drinking, it means restriction. But think about it. Patient with diabetes insipidus, they're thirsty. They're drinking water, but they're losing it, right? Even though they're drinking, they are polydipsia, they're drinking, they're still losing what? The water. Therefore, if you deprive them, it's not going to solve it. You deprive patient who has what? Dysprogenic, psychotic problem. They are the one that you restrict them. Or SIDH, they have too much retention. Now bring that content. What do you think in the question form, the answer I give you? Now see which one resembled what I was thinking. If I stop them from drinking, it's not going to change anything. That's all, because it's not central diabetes insipidus, whether you deprive them or not, it's not going to solve it. Therefore, which one is your right answer? You see how you can figure it out. Which one is the right answer? If you deprive them, it's not going to solve it. They will still have diabetes insipidus. So if I deprive them, their urine, their weight gain, they gain weight with concentrated urine. No, they're not going to gain weight. They're not going to. This is like solving the problem. It's not going to happen. They still don't have ADH. Their urine output will continue to increase, but it's not going to be concentrated. It's a trap. I saw a lot of people pick it, but you were not looking at the full answer choice. Their urine output will continue to increase because deprivation will not solve it. So they will still have what? Central diabetes insipidus. That means their urine will be dilute and their urine output goes up. It's a trap. I intentionally set it like that so that you can pay attention to answer choice. Yes, urine output is high, but if your urine output is high, the urine will never be concentrated, right? That's a trap. Their urine will remain dilute. because that's what central diabetes it is, and they will still remain dehydrated. So this one is the right answer. Urine osmolarity is not going to increase, which is the same as B, right? So I told you, watch the answers and look at it. If osmolarity increase, it means it's concentrated. Therefore, D and B are saying the same thing. Don't pick it. Sorry, those are hard questions designed to let you think and figure out the answer choice without not picking it like that. So, how would the case study look? Short one, right? 35-year-old admitted to the neuro step down after what? 12 hours after undergoing transrenal surgery to remove pituitary tumor. The nurse noted that over the past 6 hours, client has a urine output of 1200 every hour. That's a lot, despite no diuretic being administered. How do you answer? Case study, buzzwords. Patient, break it down. Keywords is what? In the first two sentences. Patient just admitted to the neuro step down. What happened? He had surgery. What kind of surgery? Transfusional surgery. That means he went through his nose to the brain. It's a brain surgery. I told you, it does not matter. Brain surgery involving what? Pituitary gland. And I told you, every time you have surgery involving your pituitary gland, watch your ADH will go up or down. You can get SIDH or DI. But what is happening to this patient? Within 6 hours, every hour is peeing over a liter. Therefore, this is not SIDH, right? And look at it. He's tachycardic, he's dehydrated. His blood pressure is going down, dehydrated. Respiratory rate is becoming septic. Look at the lab work. Is sodium too high? Serum osmolarity too high? Urine specific gravity low? His BU and creatinine is normal. I've already give you the diagnosis. This is the way they'll ask you. This is the way you analyze the question. The first two sentences, you're able to figure it out that this has to be diabetes insipidus, right? Keywords, and you continue using it, and then you use it to answer the question. Therefore, based on the data, which condition the client is most likely experiencing? It's not SIDH. The urine output is too high. It's not diabetes mellitus. We do not talk about glucose. It's central diabetes insipidus. It's not nephrogenic, right? Nephrogenic, you have to be taking some medication, right? You have to be taking some form of medication. Therefore, this is central. Which intervention should the nurse expect to initiate first? Fix the problem. What are they lacking? What do you think? Do you want to bolus them 3%? Do you want to give them desmopressin? Do you want to insert some folate? Do you want to restrict fluid? This is what you see in the NCLEX. They're playing with your content, playing with your emotion. See which one you can get trapped with. But don't do that. Hold your ground. Hold fast. Tell yourself, this is central diabetes insipidus. I'm not going to change my mind. I know this patient is lacking ADH. I know they may need folate. Well, if they can pee, they can go to the bathroom and pee. Why would I set folate and their sodium is going to be high? Why would I give them 3%? I know this is not what? Dysprogenic. It's not a psychiatric problem. Therefore, I'm not going to restrict them. Therefore, give them what they need, right? You know the answer choice. You give them desmopressin. Don't restrict fluid. Fluid restriction is not indicated in central diabetes insipidus. What is the best indicator that the client is responding to treatment? Think about it. Go down to the content. Central diabetes insipidus. They peeing too much. The urine concentration is low. Serum's osmolarity is high. If you give them desmopressin, what is going to happen? Their urine output is going to decrease. Then it will return normal. Their serum osmolarity will try to be normal. Their urine specific gravity will try to be normal. Which of those should you pick as best indicator of treatment? Pick that. When you see that kind of question, pick the reason why you give them the medication. That is the way to answer this kind of question. I give you desmopressin because I want it to do what? To urine output increases. It's not supposed to do that. Your urine output decreases. Urine become darker. No, that is side effect now. That means you absorb all the water. Now the urine is what? More darker. If you don't think about it, always be careful when they give you the medication, right? Serum sodium decreases to normal. That's the idea. I know you have DI. I know your urine output will slow down, but I don't want it to be concentrated. I want it to be normal. Every neuro endocrine question and you're treating it, try to bring them normal. Hypothyroidism, I'll bring you to normal, right? Hypercalcemia, I want to bring you to normal, no hypocalcemia. DI, I want to bring you to normal. I don't want you to become SIDH. When your urine become darker now, you are now SIDH. Therefore, this weight is not going to decrease, right? You bringing them normal, right? They're going to probably gain weight. So they may gain weight a little bit from water retention. So watch for that. This is all what these questions is about. Which findings should the nurse report immediately to the healthcare provider? Why? The client has been receiving desmopressin for 2 days. It's the same thing we just saw, but I want to emphasize more. Patient is on desmopressin for 2 days. What do you think? Which one should you report? One, urine output decreased from 1200 to 100. Think about it. They pee 1200 every liter an hour. And if I bring it to 100 an hour, that's almost normal. It's even more. Nobody want to pick 100 an hour, but they were peeing 1200 an hour. I'm still not satisfied, but this is getting better. It's not bad thing. So I don't need to report it. You understand that this is the way you should see it, right? Right. Which finding should you report immediately to the healthcare provider? Right. Urine specific gravity increases from what? 1200 to what? 1.5, right? That is, what do you think about that? Serum sodium drop from 150 to what? 135. Patient report of headache. Right. So these are some of the things is requiring you to think like I'm bringing the urine output down where it's fine. I'm bringing the urine specific gravity to normal is good. I'm bringing the sodium to normal. That means A, B, C is not. If you start having headache, it means you're retaining too much fluid and you are fluid overloaded. That's why you're getting headache. Now, what key teaching should the nurse include before discharge if the client will be taking desmopressin at home? This is all based on that medication. Therefore, if we're going on with desmopressin, monitor daily weight and report weight gain in 24 hours. Yes, that's not a bad thing. Take the medication only when you feel very thirsty. No, you should not do that. You should keep on taking, just because you're feeling thirsty, that means you're causing more problem. Wear a medical alert bracelet, right? There's a reason why they should wear a medical alert bracelet. What do you think? Because DI always it look like DK, right? A lot of urine, and then they polydipsia, they want to drink a lot of water, they dehydrated. And if they don't know that they're taking desmopressin and they have a problem, the emergency medicine people will give them in medication, treat the patient like he has DKA, but this patient is not DKA. So anybody taking desmopressin should wear this alert bracelet because they're going to get confused. They're going to lose a lot. They're going to retain water. Their sodium can go down, and they develop SIDH, and they will have confusion. So that's why they have to do that. Okay. Notify your provider if you have headache or confusion, right? That's not bad, right? So what is the question? If the client will be taking, select which one should you include, right? Drink plenty of water. Drink plenty of fluid, even if not thirsty. If you drink too much water, it's going to cause more problem. Remember, ADH is going to absorb water, the desmopressin, and so there will be fluid overloaded. If you drink too much water, you causes hyponatremia. So this is what this question require you to think before you pick the answer choice. But this is the ACD is the right answer choice based on the content. And the last one, same thing. The client present to the emergency room with confusion after taking the medication for several days, right? What intervention are indicated? Select or apply. Patient goes home, is taking desmopressin. Now he came in back with confusion. What do you want to do? Assess their sodium level. Of course, no brainer, right? Plays on seizure precaution. Yes, because he has what? Hyponatremia, most likely. If a patient is on desmopressin and come back with confusion, it's because we've retained too much water, you gain water, now you have hyponatremia, you develop SIDH, and you have seizures. So seizure precaution. Insert Foley immediately. I told you, you don't need to. If they can pay, well, don't worry about it. Monitor level of what? Consciousness. No brainer, right? Provide oxygen 2 liters via nasal cannula. I did not tell you the patient is hypoxic. Oxygen, you don't need oxygen all the time. So this is not indicated. Evaluate for recent desmopressin use. Yes, make sure. And then don't give them glucose without checking their glucose level. You can't bolus them. You got to check it. So some of the answer choice is a knee-jerk reaction. There's no indication this patient is hypoxic. Give them oxygen is not indicated. Giving somebody glucose without not checking what is glucose is also not indicated. Inserting the Foley just like that does not help the situation. So this is the end of the case study. But what does he highlight? It's the lecture that we gave so that you can understand what it means when it comes to diabetes insipidus. It's a good endocrine question you can expect to be asked in the NCLEX.